This training actually arose out of a number of historic circumstances. One was the overall DOD VA Integrative Mental Health strategy. The initial meeting was kicked off by the Secretary of Defense, Secretary Gates at the time, and Secretary of the VA, Secretary Shinseki. This is not a very common occurrence, and it signaled a very big event for psychological health support across the two departments. The goal was better continuity of care and better care for our service members, veterans, and their family members. Now, the Integrated Mental Health Strategy, or IMHS, identified 28 areas. One of those 28 areas, or 28 top priorities for DOD and VA to integrate around, was chaplains' roles in mental health. That's a second historic issue that was one of the top 28 priorities for DOD and VA. So that gave us permission to do some surveys with DOD and VA chaplains and do site visits. Another historic event, because this was the first time, to our knowledge, of a survey of the scope we provided that used the same survey items, the majority of the items, with both DOD and VA chaplains. So we had answers on the same questions from both DOD and VA chaplains with remarkable participation rates. In addition, we did multiple site visits across DOD and VA treatment centers to get a better idea of what was being done on the ground at the point of care.
The overarching goal of the integrated mental health strategy as it pertained to chaplains' roles was to really look at what is the current state of integration between chaplains and mental health care providers, both in the Department of Veterans Affairs and in the Department of Defense. And then, based on that information, to come up with a series of recommendations for how we might move forward and better integrate the two services.
How do chaplains and mental health work together currently? And are there benefits or challenges with integrating chaplains more with the existing mental health system? What we found was really neat. There are a number of great opportunities for us to support mental health and chaplains.
So the survey that we did was an online survey that was sent out to chaplains in DOD and VA and took on average over 40 minutes to complete. So we were able to get a lot of information from these surveys that really guided the recommendations that we came up with. One of the amazing things about this survey, at least from my perspective, was that over 20% of the military chaplains who completed this survey were deployed in a combat zone at the time that they completed the survey. Now, we had very good response rates both from the military and the VA chaplains who were invited to take the survey. Over 60% of our military chaplains who were invited to take the survey completed it, and 75% of our VA chaplains who were invited to take the survey completed it. Consistent with findings in community settings where individuals with mental health problems often turn to clergy persons, we found in our survey that indeed many chaplains understood themselves to be less stigmatized providers than mental health. In particular, we found that approximately 3 out of every 5 VA chaplains and 4 out of every 5 chaplains in the Department of Defense perceive that veterans or service members with mental health problems commonly seek help from the chaplain instead of from a mental health care provider. Now, nearly all chaplains in our survey reported valuing mental health care providers, understanding the role of mental health care providers, and feeling like they could closely collaborate with mental health care providers. So our chaplains did not indicate that they tended to have stigma toward mental health care providers, but rather that they understood that veterans and service members frequently still do have that stigma, and because of it, tend to feel more comfortable at times turning to a chaplain. Another one of the things that we wanted to find out about in our survey of chaplains was what kinds of problems do chaplains often have veterans and service members turning to them with, and what kinds of problems do chaplains feel prepared to encounter? And so to answer these questions, we came up, along with our task group, a list of 32 different mental health, physical health, and spiritual problems that we thought chaplains encountered with some degree of frequency. And we presented these 32 different problems to chaplains who took our survey, and we asked them 2 questions. First, we asked them, how frequently do you see veterans or service members with the described problem? And then the second question we asked them was, how well has your training prepared you to care for veterans and service members with the following problem? What we found was that chaplains reported very frequently seeing mental health problems. In fact, they reported seeing mental health and psychosocial adjustment problems much more frequently than they reported seeing spiritual health problems. So some of the most common things that chaplains said veterans and service members turn to them with are problems with anxiety, anger, work stress, family stress, PTSD, and depression. When we asked, what are the problems that you've been most equipped to care for by virtue of your training? What we found is consistent with what we would expect to find in a group of spiritual care providers. We found that they said they were most equipped to care for things like difficulties with forgiveness, difficulties with guilt, and struggles with one's religious or spiritual belief system. Now, what's very intriguing as we consider better integrating mental health and chaplain services is that if chaplains can bring to the table these kinds of skill sets, training, and being able to care for veterans and service members who have problems with forgiveness, who have problems with guilt, who have problems with their spiritual and religious belief systems, if we can bring that kind of expertise into the care of veterans with mental health problems, we are going to enhance the overall care of these veterans. When we think about the research indicating that veterans with PTSD tend to have more severe PTSD when they have guilt on board, when they have problems with forgiveness on board. What this research is telling us is that we have a group of care providers and chaplains who can come alongside mental health care providers to enhance the care that we provide to those with these types of mental health problems.
As we continued in our integrated mental health strategy study, we not only looked at the survey results, but we also wanted to look a bit more in depth to understand the context in which they served, the settings where they served, whether it be in rural or urban areas in the case of the Veterans Administration, whether they were in operational settings or more clinical settings in the Department of Defense. And so what we did is we decided we were going to conduct site visits. And in conducting those site visits, we planned it out and intentionally identified 33 different sites across the country that were dispersed into, in the case of the Veterans Administration, what we call VISNs, these networks of medical treatment facilities in various parts of the country, to where they were in diverse locations. As well as in the Department of Defense, we wanted to cover all branches, the Navy, Army, Air Force, and Marine Corps. And we wanted to have the diversity of, in this case, and had a unique opportunity to interview not just chaplains, but mental health providers. So we had half, approximately, Department of Defense locations and half of the Veterans Administration locations, and we had half, approximately again, mental health providers and half chaplains. So it really gave us a nice blend and diversity of responses so that we could begin to better understand their perceptions of one another, of one discipline to another, how they may have already put into place very successful integrated practices in their own facilities, how they interact with one another in terms of chaplains and mental health care. So what we discovered during that time is that relationships were paramount. It just seemed like where there was successful integration, someone took the initiative, either a mental health provider or a chaplain, and in most cases it was the chaplain that took the initiative, established the relationship, saw a window of opportunity in some particular training event or response to a crisis that may have occurred, and they began developing a relationship with the mental health provider, who then invited them to be part of some particular event, maybe a group session that they were having or some type of training event. But the truth of the matter is during our site visits, we discovered that most mental health providers simply do not understand what chaplains do, what they bring to the table, how they go about doing what they do. And so we learned, question one, what do chaplains do? We need to find a better way for chaplains to explain that and so the mental health providers can understand it. There was a receptivity among most of the providers that we interviewed for chaplains to be integrated into mental health care services. They saw a real value in that and saw it filling a gap that had been identified. They just didn't know quite how to go about doing that. And some of the questions that came up were, the diversity had to do with the diversity of backgrounds that chaplains have, how they receive their education, what are their competencies as it relates to mental health, what was their formation, and how does that affect the way in which they might approach a patient that's receiving care within mental health. And so all these things were not so much a reluctance or a sense that chaplains were not prepared to serve within mental health, but they were really more a comment about a lack of understanding, and that they were very interested to learn more about what chaplains do. So the site visits themselves ended up resulting in many of these providers thinking for the first time about all the possibilities, and as a result they came up with all kinds of creative suggestions in the midst of the interviews. We also learned that proximity was a huge issue. When chaplains and mental health providers were co-located or in close proximity to one another, the natural effect, what one might expect, the natural effect is that relationships were more easily established. It was a more natural process. They tended to cross paths with one another throughout the day, and as a result, the relationships again, they grew. Trust was established, and they began to integrate some of their practices in a very natural way. The concern is that although we found pockets of innovative practices that were quite successful, we also discovered that there was rarely a formalized process in place for this to continue. Once, especially in the case of a transient type of community within the Department of Defense, where someone is relocated every 3 to 4 years, and sometimes every 2 years, the chances of that particular integration continuing was very small, very minimal, because it was so driven by someone's individual initiative. And so it was a recognition in our site visits that it was going to be really important for us to look at how can those integrated practices be formalized, how can service agreements be established, how can we begin to identify the kind of formal steps that need to occur so that these institutions can take advantage of what many are now recognizing as a great possibility in the care of our service members in mental health.
It's not easy to work with persons that we don't understand or know or with regard to their training background or their own educational framing of the care of persons in a healthcare setting. So I think the responsibility is upon all of us, both mental health providers and chaplains, to put in the time to understand how our colleagues are trained, how they're formed, what levels of expertise they have, what they don't claim to be able to do, and then to be able to work as good collaborators and colleagues. One of the practices that we want to advocate within mental health and chaplaincy is the commitment to joint training and opportunities for learning more about how each other, when thinking of mental health providers and chaplain colleagues, are understanding a patient, how we're thinking about them, how we're framing our interpretation of what we're hearing, and then learning how to communicate that most optimally to each other. And we're continuing to explore ways to more adequately foster that type of communication across our disciplines and within the breadth of our work together.
There have been many times when chaplains have talked to me about situations that they're dealing with service members. One of the most common is concerns about suicide, either a service member that made an actual attempt or has had serious thoughts about it, and the chaplain sometimes is asking for assistance. I also know that they deal with death in families, serious illness in families, and service members that are really struggling trying to find meaning in their life and what to make of these issues. And then, of course, certainly with the 12 years of war that we have been involved with, where we have lots of service members who have witnessed death, witnessed severe injuries, been injured themselves, have seen maybe civilians die, maybe they didn't rescue their buddies in the combat situation. These have very profound impacts on them. They affect their view of life, and they frequently turn to chaplains to seek guidance. And sometimes when they do that, they show symptoms of concerning emotions, and that allows the chaplain to sometimes seek assistance with mental health care providers to perhaps assist or provide some guidance.
I've actually found this to be true among many of my mental health colleagues, that they don't know exactly what chaplains do. I can remember an experience from when I was a psychology intern, and the chaplain at the VA hospital where I was doing my internship came and spoke to our internship class about what it is that chaplains can offer. And what was interesting, as a result of just this 1 hour simple didactic where this chaplain came in and talked about, here's the kinds of things that I do with veterans here at this VA hospital. After hearing that, a number of my psychology trainee colleagues commented to one another, gosh, I never would have thought of referring to a chaplain before that, or if I had thought of it, I would have thought that perhaps they were going to try and do some religious conversion type thing with them, or they were going to try and proselytize the veterans. But after hearing this chaplain describe what they do and how they approach spiritual care, I can really see how that contributes to not only overall health, but could contribute to better mental health outcomes for the types of veterans that I serve. And I think I'm going to be more willing to potentially refer patients to a chaplain, just as a result of that chaplain taking the initiative to do a simple explanation of, here's how I approach chaplain work within the hospital.
One example of the inner networking between chaplaincy and mental health occurred soon after 9/11. And this was an occasion where we had chaplains ready and standing by to be deployed, but we never received the call. And after the event was over, we found out that there was an absence of chaplains, particularly at the Pentagon and other areas. We tried to investigate why. We went to Washington and we found out basically from the Red Cross, from mental health folks there, and from the Emergency Management Strategic Healthcare Group, that chaplains did not have the right training credentials to access all of the deployment criteria that was needed. So we started to developing a curriculum. We took information that was required from mental health in terms of disaster preparedness. We took information from the Emergency Management Strategic Healthcare Group, and then also the American Red Cross. And we incorporated all this information after it was cleared with each discipline into one 3-day cycle. And over the next 2 or 3 years, we exported this curriculum to medical centers throughout the United States. And we came in on a Monday, taught for Tuesday, Wednesday, and Thursday, left on a Friday. But each time we left, we invited the mental health professionals, we invited all the chaplains in the vision area, and we were able to leave knowing that that group knew who the players were able to visually see each other and know the job and responsibility that each had if there were, in fact, a disaster that occurred near their facility.
I'm often asked if VA chaplains work in a mental health environment, and I would say yes, by all means. Probably half of all VA chaplains work within mental health, and I would say probably slightly more than half. Many VA hospitals have mental health as a primary mission. It's broken down into things like substance abuse, homelessness. Sometimes the two go hand in hand, locked and open psych. There's always a chaplain assigned to the psych units. Domiciliary work. These are often graduates from a previous psych unit to the domiciliary, and there's always chaplains assigned to the domiciliary. Dementia units, chaplains assigned to dementia units as well. And also, kind of a new kid on the block, the intensive outpatient programs, which is kind of a daycare type thing, where veterans have graduated from a previous mental health program and now come back as day patients, and chaplains are assigned to those staffs, teaching classes, counseling, doing assessments, things of that nature.
There are many things that chaplains can offer to mental health, especially in the area of trauma. One of the strongest predictors of recovery following trauma is social support. Judith Herman, who did a lot of research and wrote on trauma, said, "The fundamental stages of recovery are establishing safety, reconstructing the trauma story, and restoring the connection between survivors and their community." Chaplains are all about building community, reconnecting one to a community of support. Military chaplains, as I said earlier, can be an advocate for that service member within their command. They can connect them to a community that cares for them and supports them. Chaplains can provide a meaningful network of hope. They can reinforce an individual's sense of belonging and purpose in the community. They can help service members gain a sense of connectedness to that caring community, which will help maintain hope in the midst of stress, whether it's through friends, family, shipmates, soldiers, faith. They can help them stay anchored. Those who are suffering, the lost, the lonely, the unloved, and not valued, when they go to a chaplain, that chaplain bears witness to their suffering, helps them give it a name, helps them work through that suffering so that they're not alone. They provide a framework to help connect with a higher power. Many times when a service member comes to a chaplain, it usually starts off with something like, "Chaplain, have you got a minute?" which is an indication that they want to spend some time talking with the chaplain. People tell chaplains things that they don't tell anyone else. And so it's important to honor service members when they do in fact come to talk to a chaplain.
I recall my very first, right out of chaplain school, first assignment, reported to a ship that had gotten underway. They were about 7 days into their deployment, and I met the ship over in Israel. And the Tel Aviv had been bombed a day or two before I arrived, and so there was obviously a great deal of security, picked up by an unmarked van, and a petty officer I'd never seen before in my life, and he identified me and hopped in the van, made our way to the shore there where the Liberty boat had pulled up to take people back and forth from shore to the ship. And as I approached the Liberty ship, I got on board, and shortly thereafter learned that the third in command had just heard news that his father had died. And he was just in shock, trying to make sense of that, knowing he was at the very beginning of a deployment. He was a key, among the key leaders of the command, and was trying to discern, did it make sense for him to go home or to stay and carry out the deployment, and the mixture of emotions that one can only imagine when something like that occurs. We made our way to the ship. It was 10 o'clock at night. It was dark. Reached the brow, began to ascend the ladder, and as I looked up, I saw the fourth in command on the ship with his sea bag upset over his shoulder and ready to leave. He had had all he could take. The stress had exceeded his ability to cope, and he was ready to walk away from the command at that moment. And so we went in and sat down and talked, and it really hit me that this is what chaplaincy is about. It's about navigating whatever comes your way and dealing with people in the midst of very stressful and demanding environments, oftentimes in an isolated setting away from their normal means of support, their family members and loved ones.
My first patient at a hospital that I worked at that I encountered, who was a Vietnam veteran. He'd been a member of a Riverine squadron, been exposed to tremendous amounts of Agent Orange chemicals, and he was in the hospital dying of cancer. As I began to get to know him, I discovered that he was dealing with issues of unresolved anger and grief, either over the life that was lost, his buddies who died, over his hatred for the culture in Vietnam and some of the things that happened there. He just had a lot of anger and grief. And so as we worked through them, in the last days of his life, he was able to come to a point where he felt he could be at peace and die in peace. And as I think back to that particular sailor, I think of that's the first memorial service that I ever did, and it's always stuck with me. And so working with him, it was really a matter of helping him frame or reframe the life and death experiences that he'd been through as a Vietnam veteran.
Another example was in the Veterans Administration. A Vietnam veteran had actually committed himself. He was suicidal, and he was really concerned about his own judgment, his ability. He knew he wanted to live. He didn't want to commit suicide, but frankly, he had lost all hope and meaning in life, and he wanted help. The psychiatric nurse in that particular unit recognized that some of the things he was struggling with sounded more like they had to do with spiritual crisis than mental health crisis in some ways. And so she asked if I would come up and talk to him. And as we talked and he told me his story, he explained that he had been on a ship in the Navy off the coast of Cambodia during the evacuation at the end of the Vietnam War. And he watched many people be gunned down by the North Vietnamese, and their bodies were floating by the bow of the ship, as he was manning a 50 cal gun and trying to protect them as they made their way to safe evacuation. And that haunted his memory, and he really struggled to find meaning. And then he had a neighbor down the street who was diagnosed with cancer. And he found tremendous purpose and meaning, and it became kind of his sole purpose in life was to take care of his neighbor who had cancer. And this went on for almost 2 years. And they had developed a tremendous closeness. It was kind of a no pretense relationship, and they could be totally honest with one another, and it became really kind of the focus of his life. And of course, in time, his friend's cancer progressed and he died. And this was the moment that he began to have his crisis. And he began to seek help, thank goodness. And so what we talked about was what gave him meaning in life, what were the things that were important to him, why was this relationship so valuable to him? And as he began to discover why he felt so close to this individual he was caring for and why that fed him so much, he also was able to begin seeing new ways and discover other ways in which he could meet that value that he had and meet that desire and reestablish meaning in his life. And to my knowledge, he continues to this day.
When it comes to dealing with spiritual resilience, I think about a Navy spouse who was referred to me. This spouse had been diagnosed with dissociative identity disorder and was in therapy to deal with her many personalities that were a result of incest and religious ritual abuse as a child. And so as I worked with her and her therapist, we talked about the spiritual resilience that she had and helped her claim that as she tried to work through the trauma that she had suffered for many years, and to affirm that in fact she was a resilient person and had been able to survive many horrors as a child. A sailor once came to me to talk about issues of reconciliation, and he had actually been referred to me by his primary care physician because he had said to his physician that he had feelings of sadness and anger. And so the doctor said, "You might want to talk to a chaplain." I learned that he grew up without a father. His father had been a Korean War veteran, an alcoholic, and he didn't know his father at all. And as we began to work through those issues of abandonment, anger, he got to a place where he felt he was ready to reach out and reconcile with his father. Unbeknownst to him, when he reached that point of reaching out to his father had been diagnosed in a very late state of cancer and was dying. So he made a trip to see his father. They began talking about memories and things that they had missed out on, both of them. And during that time together, in his father's last days, the father gave military mementos that he had collected over the years and passed them on to his son. There are a few common misconceptions when it comes to chaplaincy. Some service members think that the chaplain is only there if one is religious, spiritual, or a member of a faith community. Others may fear that the chaplain in some way is going to try to proselytize them, to convert them to a particular religious belief. Other service members may think that the chaplain doesn't understand the pressures of the common service member as it relates to their job and the stress and the operational tempo that service members work in.
I think sometimes that we're understood as not wanting to get our hands dirty, and so we are perceived as those who maybe came out of a parish ministry or a synagogue or something where we were not accustomed to getting out and kind of mixing things up and doing what so many of the service members have to do in their training and in an operational setting. And so I always found it helpful, for example, in community service work, we had the opportunity to do all kinds of projects where rather than try to convince anyone of who we are, it's much easier to go out and just be with them and to do it with them. And so we would go out and we might do construction work and repair work in a foreign country, in their hospital or in a women's shelter or in an orphanage. And there have been so many different opportunities out there for the United States to show the flag, as they say, and provide care and outreach to various countries and appeal to their needs. And by doing that, working side by side with the service members, they begin to see the chaplains are right in there in the trenches with them in so many cases. Again, it lends to an effective kind of relationship in the midst of crisis because it really opens the door and provides a safe place.
Other service members may think that the chaplain does not have confidentiality and what they share with the chaplain will be reported to the chain of command. Chaplains in the military have 100% confidentiality, and what's said to a chaplain stays with the chaplain.
It isn't an easy topic. Each of the branches have their instructions that spell out precisely what is meant by confidentiality among chaplains. And they continue to develop those and refine them so that the understanding is more clear. But when you enter into the healthcare environment and you have the complexity of HIPAA reporting and HIPAA requirements, as well as the reporting requirements of the providers, which are much different than the chaplains in a clinical environment, you start to see that there's nuances all along the way on the topic of confidentiality. At the end of the day, service members and veterans want to know that they have a safe place to talk about whatever it is that they want to talk about.
And finally, some may be concerned that chaplains can't effectively handle any number of uncomfortable situations that service members may want to talk to them about, that maybe they're not trained, or because they're religious people, that certain topics are just off limits.
We are untouchables, so don't approach us with the hard subjects or subjects that may have a bit of a color or crassness to them, because they our ears may hurt if they were to share that news with us. The reality is, we're just like the rest of them, and one of the benefits of serving alongside is we see and experience and participate in so many of the same things that they do. So oftentimes they will, over time, begin to understand that pretty much whatever the subject is that they're struggling with, that we can be a resource for them, and they realize that we're human with all our frailties and challenges and our struggles, just like they are. We have our own pain, our own suffering, and our own joys, and hopefully as chaplains we've learned to navigate that and use our faith and our spiritual disciplines and practices to kind of help navigate our way through that ebb and flow of life.
There are 4 capabilities that chaplains bring to care: facilitate, provide, care, and advise. The first capability that chaplains provide is facilitate. That means accommodating diverse religious ministry requirements. It may mean that I have to refer a military member to someone else of a specific faith group because they are not a part of the same tradition that I come from. The second capability is provision of religious ministry. That means meeting specific faith group needs. Might be worship, might be sacraments, might be counseling, so that those sailors who are of a similar religious background that I'm from, then I would provide direct provision to help them with their religious needs and requirements. The third capability is caring. Delivering specific institutional care, counseling, and coaching, which attends to a service member's personal or relational needs outside of any faith-specific context. And by this I mean caring for all with dignity, respect, compassion, reinforcing the value of the human life. Many come to a chaplain not necessarily seeking to answer the why questions that they face in their life, but they need a space in which to explore the why questions. Chaplains help validate the grieving process. They give service members an opportunity to work through and process whatever kinds of grief and loss they're experiencing. Because it's a sacred privilege to work with those who are suffering, chaplains often provide a framework for looking at what's happening in one's life and again struggling with the questions of why that all of us as human beings face. The fourth capability is advice. This means working directly with commanding officers on issues related to morals, ethics, spiritual well-being, or the general morale of the crew of that command. And in a non-combatant status, chaplains advise commanding officers on the impact of religion on operational events. We often serve as the duty humanitarian and advocate for command, the eyes and the ears of leadership. And we provide a ministry of presence, which often leads to a prophetic role that chaplains play in a command on behalf of others, whether it's dealing with issues of righteousness and justice, mercy or compassion, and humility in a leadership role.
really excited about the tremendous opportunities that can come about by having closer collaboration between chaplains and mental health providers. There's so many things that chaplains know that if mental health providers are not aware of, it really interferes with their ability to perform their duties as well as they could, and vice versa. And by providing a united front, by working closely together, by sharing information, by being more visible together, I think there's a tremendous benefit for service members and their families when they see the interrelationships, and so that really the whole person's needs can be addressed as opposed to feeling like it's compartmentalized. Well, here I go for learning more about my spiritual concerns, and then over here I go if I have, major psychological symptoms, when actually by working together you can actually get some of both with either type of professional.
There are a couple parallels with the field of psychology and this initiative that I think are useful to consider. There were some classic studies by people like Eysenck that questioned whether psychology had a positive impact. And that led to a lot of research in the area of outcomes for psychology. There were a lot of psychologists at the time who said much of what we do cannot be measured. And in fact, if you try to measure it, it will probably dilute the impact of what we do. And I think that's a legitimate concern. What we found over time was that we could measure a lot of the significant things psychologists do and other mental health providers, and it helped us out as a field by developing a clearer language about what we do and an evidence base about some of the major impacts of what we do. In pastoral counseling practices, that it may be possible to better measure some of what happens in pastoral counseling and inform both mental health providers and chaplains on what their main goals, what their goals are, and what their approaches are, and the impacts of those approaches.
So when we think about the evolution of psychotherapy over the past 50 to 60 years, one of the things that we've seen is that cognitive behavioral treatments have become much more prominent. This is in large part because of the evidence-based psychotherapy movement. When we look at evidence-based psychotherapies, one review of the literature suggests that perhaps over 80% of the psychotherapies that we consider to be evidence-based fall into the cognitive behavioral treatment class. And so cognitive behavioral therapy, or CBT, has gone through a number of what have sometimes been referred to as waves of paradigms that have influenced CBT over the last 50 to 60 years. The first wave of cognitive behavioral therapy was really just behavioral therapy, used predominantly classical and operant conditioning paradigms to think about how we approach the care of persons with mental health problems. The second wave of CBT is when the C really was introduced, was a much more cognitive paradigm, and cognitive therapy was introduced alongside of behavioral therapy. And with cognitive therapy, we really began looking at what's going on inside people's minds, what are they thinking, how is that contributing to the development and maintenance of mental health problems, and can we do something about it? In particular, can we find ways to address those cognitions and make them, quote, more healthy to lead to better mental health outcomes? The third wave of CBT is much more recent, and it's characterized by a much more diverse group of psychotherapies, including things like metacognition, cognitive fusion, emotions, acceptance, mindfulness, dialectics, spirituality, and therapeutic relationship. And so, third wave cognitive behavioral psychotherapies clearly cover a diverse range of different psychotherapies, But within that diverse range, a number of the psychotherapies in this somewhat nebulous class do have a much more overt emphasis on spirituality, things like mindfulness, even acceptance, and the therapeutic relationship, at least as that's often been understood within practices of chaplaincy. And so it's interesting for us to think about how some of the newer movements within evidence-based psychotherapy really cohere quite well with some of the practices within chaplaincy, and I think begin to invite a dialogue around what are some of the practices that do contribute to health and healing, as well as a dialogue around what constitutes health and healing. How should we think about the types of outcomes that we're measuring in the research that we set up within mental health, or within the types of care that's provided by spiritual care providers?
When we think of the most important dependent variables or outcomes to be considered in relationship to the work in spirituality and health, I am convinced that we need to be thinking about human flourishing rather than cure. One of the challenges we need to consider together is how to think about human flourishing in a much more communal sense rather than in an excessively individualistic fashion. I think we need to think about human flourishing as being something that inevitably occurs in the context of interdependent lives, as something other than just my own individual experience of some emotion or some sense of an internal process of my own. It's frequently been understood as a very individualistic phenomenon of happiness, contentment, personal sense of well-being, personal satisfaction in some way. None of those are bad things. I'm not convinced that they are the most optimal way to think about and to ultimately conceptualize human flourishing, especially when we're trying to consider the intersections of spirituality and health. I would want to appeal initially that there is a domain of awareness and reality for our patients that has some configuration that includes a tolerance of disappointment, an ability to have an awareness of it's not going to all be like I hoped it would be. There will be disappointment, but yet in the midst of disappointment, I can claim gratitude. And in the midst of those ongoing challenges of life, that yes, I can use tools such as acceptance commitment therapy and evidence-based therapy that a psychotherapist might be able to provide for me, at the same time that I can really do some spiritual exploration with a chaplain, and then that I might even blend those at times in ways that will enhance my capacity to, in a context of anticipation of psychological flexibility, mindfulness practices, and good spiritual exploration and care by a chaplain, actually experience human flourishing.
Hopefully these videos have begun to give you some ideas on how to integrate mental health and chaplain services to better meet the needs of service members and veterans. And perhaps this is something that you've already done a great deal of. Maybe you're in a context where mental health care providers and chaplains are regularly part of interdisciplinary care team meetings. Or perhaps you even lead a group that may be co-facilitated by a chaplain and mental health care provider. Whether this is something that you've already done a lot of, or if it's something that's relatively new to you, we'd like to offer a global suggestion and then invite you to consider a number of specific domains in which you might look at care practices and how those care practices might be changed or improved to better integrate mental health and chaplain services. The global suggestion that we would offer is, if you haven't already, open a dialogue between mental health services and chaplain services in the context where you are. We know from a variety of sources, from research as well as some things that we've talked about in these videos, that on the mental health side in particular, there can be a lack of awareness about the other discipline, about chaplaincy, about what chaplains do and about what they don't do. And simply opening up a dialogue can begin to go a long way in making sure that there is a platform and an environment in which veterans and service members who have spiritual needs and mental health care needs can have those needs addressed by providers who have the appropriate skill sets. With respect to some of the specific domains that we would like to mention, we have a partial list. There's certainly a number of other things that we could add to the list that we're going to go through. And some of the things on this list may not apply in the context where you work. But we offer these as a way to hopefully begin to inspire some ideas of concrete things, practical things that you might do in the environment or the context where you work. So the first domain that we would invite you to consider is the domain of screening. If you're not in a healthcare environment, you may not think in terms of screening. You may think in terms of identification. So if you're a chaplain, how do you screen for or how do you identify individuals who might benefit from mental health care services? And if you're a mental health care provider, how do you identify those individuals who might benefit from chaplain services? Is there an existing tool or guidance on how you should screen at your facility or in the context where you work? If there is, become familiar with that. If there's not, how could screening take place in the environment where you work? And how might you even look to potentially the published literature and existing screening instruments to use those instruments or adapt those instruments for your purposes and the individuals who you see? A second domain to think about is that of referrals. So if you're a mental health care provider, what's the process for referring veterans and service members to chaplain services? And vice versa, if you're a chaplain, what is the process for referring individuals to mental health services? When you make a referral, what information do you provide? And is this information in fact useful to the discipline that you're referring to? What feedback is produced after a referral takes place? And should a coordinated care plan be established or set up at the time of a referral? Finally, you might think about whether community clergy should be part of the referral process, whether it involves community clergy referring to a healthcare facility, or when patients are leaving the healthcare context, how community clergy might be part of that process in helping individuals integrate back into environments and contexts that give them meaning and purpose. Another domain to think about is assessments. So if you're a mental health care provider, do you ask about spiritual issues in your assessment? And if you're a chaplain, do you ask about mental health issues in your assessment? Could you improve on how you ask about these issues? Do you understand and use the other disciplines' assessment in enhancing the care that you provide? And how does your assessment of mental health issues, if you're a chaplain, or spiritual issues, if you're a mental health care provider, influence how you conceptualize the needs of veterans and service members and ultimately the care that you provide to them? Finally, how does your assessment inform the care that's provided by the other discipline? Another domain to think about is the domain of documentation. This really applies mainly for those who are practicing in clinical settings. So, do you document the care that you provide and how. There is perhaps more variation with respect to this issue in the chaplain community than there is in the mental health community. But understanding how one another document, depending on the context that you're in, can be very helpful. Do you pay attention to the other disciplines' documentation of care? And from your perspective, if you're a mental health care provider, how might chaplains' notes or documentation be improved? If you're a chaplain, how might mental health care provider notes be improved to help you provide the care that you're aiming to provide to veterans and service members? And finally, do you understand how your notes or your documentation is interpreted and used by the other discipline? Another domain to think about is that of communication. So are there regular times when chaplains and mental health care providers communicate about patient needs? If you're in a clinical environment, are you in or part of an interdisciplinary care team that regularly meets? How do you present patient information to the other discipline? And relatedly, especially if you're a chaplain, how do you balance respecting confidentiality with ensuring that veterans and service members' needs are being optimally met in clinical settings? Another domain to think about is role clarification. So, do mental health care providers understand who chaplains are and what they do, and vice versa at your facility? And if not, what steps could be taken to improve this? Also, is there existing guidance at your facility for what chaplains' roles are and what mental health care providers' roles are, and how the disciplines should interact? In some clinical settings, this is sometimes what's referred to as a care coordination agreement. So does something like this exist at your facility? And if not, is it something worth thinking about creating in the context where you work? A final domain that we would invite you to consider is that of cross-training. So are there opportunities where you are for mental health care providers and chaplains to receive training together? Might there be mental health trainings that chaplains could be invited to? Or perhaps are there trainings that are offered by chaplain services that mental health care providers could be invited to? Or might you think about offering some sort of training or opportunity to bring mental health care providers and chaplains together to think about how you might better coordinate and integrate the care that you offer to veterans and service members? As part of watching these videos, you've heard a number of different providers from the mental health discipline as well as from chaplaincy talk about some of the individuals that they've encountered over the years. No doubt you have your own stories. You have veterans and service members who have influenced the way that you've thought about care over the years. We invite you into this process with us, to think with us about how to better coordinate our care services so that we can improve the lives of those we serve. Thank you.